This is a 70 years old male patient, known case of diabetes, hypertension, and smoker, who presented to the emergency department with typical chest pain. Within 2 hours of a chest pain, he presented to the emergency department, and on ECG there was a frank ST elevation right from V1 to V6 with reciprocal changes, and on echo there was RWMM with moderate LV systolic dysfunction. So after obtaining all necessary clearances, he was taken for the angiogram, and this is the angiogram with the right radial route with Tiger catheter, and you can see how short the LM was, and you can see clearly there is a thrombus sitting across the diagonal in the proximal LAD with T3 flow. And if you see this caudal view, this is RO caudal view, you can clearly see the thrombus, thrombotic stenosis, almost subtotal occlusion in the LAD across the diagonal, and you can see the ostial diagonal also was loaded with thrombus. Moreover, in this epicranial view also you can see the same thing. You can see the thrombotic subtotal occlusion in the proximal LAD across the diagonal as a big LCX normal. This was the RCA fairly normal. So this is a picture after the angiogram, and there are so many difficulties as it is supposed to be a primary angioplasty. So after obtaining all clearances, we proceeded for the primary angioplasty, and you can see the difficulties in this case. You can see how the Tiger catheter was hanging in this short left main, and near the arrow in this still frame you can see the seems to be a very tight thrombotic lesion in the proximal LAD, and across the diagonal you can see the ostium of diagonal near the arrow. This is a diagonal 1, and it has also thrombus. So difficult, and we anticipated the slow flow no flow phenomenon in this patient because you can see the load of thrombus, and he was presented within the 2 hours. There's again the RO caudal view. You can see clearly in this cranial still frame, you can see near the arrow there is a subtotal occlusions in the LAD. So my plan was to put one wire in the diagonal and one wire in the LAD with XB3O catheter. I could have used JL, but JL don't give support, so I was very careful while using this XB3 catheter. So we proceeded. At this point, patient was in severe chest pain. BP was okay. It was 110 by 70 mm of SG. So with the right radial route, we proceeded for the angioplasty, and this is the BMW PTCA wire. The catheter was XB3, and then firstly wire directly went to this diagonal. You can see ostium of diagonal. So you can see I was trying to push the wire in LAD. You can see the sort of dual LAD structure is there. So wire went into this small LAD now, and somehow I managed to put the wire in this through that bend into the large LAD. So now in this MAC view, we can see we already anticipated this slow flow, no flow and all. So already you can see there's a slow flow now after putting a 2 wire. And then straight away I took a 3x24 drug-eluting stent, and without dilatation I went ahead with this stent direct, and you can see there is no flow at all after positioning the stent. And the stent was deployed at around 14 atmospheric pressure. It was a 3 stent, 3O, and RBP was 16. And as we anticipated, there is a slow flow, no flow after putting a stent. So now what to do? So now at this point of time, I proceeded with the thrombus aspiration, and I aspirated the thrombus. There was a very minimal thrombus which I could. So after thrombus aspiration, this was the cine, and you can see some improvement in the flow. Diagonal was okay, was same like earlier. Then we had given tirofibin, nicoran, and along with that we had tried adenosine intracoronary. Meanwhile, there was a ECG changes and patient's BP went down. So we tried adenosine. So in such a situation, adenosine works well. After adenosine, you can try the adrenaline. I have a good experience with adenosine and adrenaline. So after adenosine, it is the flow. So TME3 flow was achieved, and ECG changes came down, and patient's pain also came down. BP went up at this point of time. So this was the difficult primary angioplasty to this old man with no flow, slow flow after angioplasty. Now TME3 flow was achieved with all treatment, and now patient is on GP2B3 inhibitor, tirofibin and nicoran. And now he was good at this point and then shifted to ICU. The patient is doing well now. Thank you.